We can get started. So hi, thanks so much for joining us today. We have a really exciting topic um, today where we have Dr. Carrie Scott and our very own Dipanwita from Nora Health, who's going to be speaking about cognitive interviewing. I'm just going to give a very brief introduction to them both, and then we'll hand it off to them to begin. So Dr. Carrie Scott is a social scientist interested in gender, accountability, community participation, and the power in health systems. She specializes in program evaluations, particularly in the digital health space, cognitive testing to strengthen survey design, and implementation research. She's a subject area expert on community health workers and health committees. She received her PhD in international health from Johns Hopkins University and is an associate faculty in the health systems program there, and is also an independent research consultant. And Dipanwita, who many of you know, but I'm still going to give an overview. Currently she's a medical content officer at Nora. She has a master's in nursing, specializing in pediatric nursing. Yeah, she was part of the research work for this work that's about to be presented today. So really happy and lucky to have this fantastic resource within Nora. But yeah, I'll hand it off to you both to get us started. Thanks so much.
Thank you, Shirley. Hi, everyone. Good afternoon. It's morning for me here. I'm calling in from Toronto, Canada, where I'm now based, but I lived in Bangalore for 8 years and Pune for 2 years. So I'm very, close with and familiar with Bangalore. And it's just really incredible luck that all these worlds have come together. I met Shirley through the Hopkins connection, and I met Dipanwita through our work on cognitive interviewing, and then it kind of came together through Nora Health. So yeah, a lot of good luck brought us here today. So today, I'll jump in and you'll hear from Dipanwita a bit later, and we'll also both be available for the discussion period at the end. But we're going to talk about improving survey tools through cognitive interviewing. And I'll just let you to start off to kind of flag that this work arose from many collaborations with many organizations and different funders. So just to kind of shout out to all of our collaborators and let you know that this is very much a group effort. So we'll talk a little bit about what cognitive interviewing is and what it has revealed in our work. It's kind of our chance to pitch it. I hope by the end of this, everyone is an evangelist for cognitive interviewing, because I've become completely obsessed with it. And I hope you guys will feel the same by the time I've kind of sold it to you. And then we're going to talk about the methods of cognitive interviewing to kind of demystify it, and also discuss how you actually go about doing it, so you feel like you might be interested in incorporating it more in your work. And that's where Dipanwita will come in a lot more, because she has the field experience. And so she's going to share some reflection during that session. And then the last bit, we'll have lots of time to talk. Okay. So how did it all begin? This is back in 2018. I was involved in a study called the Kilkari Evaluation, and we decided to add a module on respectful maternity care to a large survey that we were going to do anyway. And it had about 5,000 pregnant and postpartum women in Madhya Pradesh. And we thought, okay, let's just study respectful maternity care. It may affect some of our outcomes of interest. How hard can it be to add a short module on one topic? So we went out the way you kind of normally do when you're trying to build a survey module. And we looked around and we found that there were validated instruments that had been developed elsewhere. There was some from Kenya. We had a colleague that very kindly shared some instruments they had been using in another part of another Hindi-speaking region of India. We kind of put them together and decided, kind of casually, let's just do a little extra checking to make sure these are really good for Madhya Pradesh. And so we planned this very small validation study. And it was absolutely mind-boggling, because we very quickly realized that there were major complex issues with the tool. And we realized, many of these issues that we were discovering through our small little study would have been impossible to detect after data collection, because what you found is that respondents would give an answer. And if you were doing a regular survey, you would simply record the answer and move on to the next question. But when we did our extra layer of qualitative work on top of the answer to those questions, we found out that they had completely understood it differently than us or not understood it at all. And that response they gave would have been recorded as true, regardless of whether they understood it and answered it in the intended manner, and regardless of any adjustment or assistance or interpretation provided by those poor enumerators that are trying to make your survey work. So from there, we designed an actual cognitive interviewing study on respectful maternity care. And this is where we were so fortunate to cross paths, Deepanvita and I, because she brought in incredible understanding of the maternity care space, of delivery rooms and obstetrics. And so that's really where we work together, is on this respectful maternity care cognitive interviewing study. And, this was testing questions. I just put an example of the type of questions it was testing. Things like the doctors, nurses, or other healthcare providers spoke to me in a language that I could understand. So there were many, many questions. I think there were about 40 questions, but that's just one example. Then I also went on and have done cognitive interviewing on family planning. This is around their knowledge and practice. So, if a woman has been with her husband and is worried she might be pregnant, what could she do to prevent an unwanted pregnancy? So that's an example of a knowledge question from the family planning module that we tested. We also studied the infant and young child feeding module. Again, these are all polling questions that have been validated elsewhere and are very commonly used. So, at what age did you introduce mashed or thicker foods to the baby's name? In other words, when did you start complementary feeding? We then looked at just one question on mobile phone access. And this is the question used in the Indian NFHS. Do you have any mobile phone that you yourself use? We tested this question. And since then, I was lucky enough to actually get hired to work with the South African government, along with a team based at University of Cape Town, to try to cognitive test the consent language that women are given when they are consenting to how their data can be used. So this was in South Africa, and they wanted to develop a good consent form for women in 6 major South African languages. So things like, can the Department of Health send you general health information about pregnancy and child health via mobile phone or through text or WhatsApp? So that's the experience so far. And I'll first discuss what it is. So there's a nice kind of fundamental definition that comes from Beatty and Willis, who are the real, fathers of this method. And it's essentially the administration of draft survey questions while collecting additional verbal information about the survey responses, which is used to evaluate the quality of the response or to help determine whether the question is generating the information that its author intends. So pretty simple. You administer the draft survey questions and you collect additional verbal information about them. What I like to describe it as is a test to make sure that the surveys are actually working. So you're here and you're asking your question, and the respondent is confidently answering a question that they've heard, but it's about a completely different topic. You're not actually meeting your cognitive domains, your mental spaces, your processing is not sharing a space, they're not meeting. So when you use cognitive interviewing, you actually try to make sure that you're both talking about the same thing. You're no longer trying to communicate about different topics. And the way it kind of works is you essentially, and there are a few different methods, but this is the way that I really like doing it, is you ask the quantitative survey question exactly as it is written. It's like basically as if you are a quantitative enumerator. Then you elicit and record an answer on the quantitative survey instrument. So you use the same response options that the quantitative team would have. Then you kind of switch gears, and Deepanvita can talk more about this, from a enumerator to a qualitative researcher, and you ask a series of qualitative probes to understand how the respondent interpreted the question and why they gave the response provided. So I'll come back around to methods, and Deepanvita can talk more about it as well. But first, I want to pitch it to you to show you how much it matters. And to do so, I'm going to talk about some of the interesting and often surprising cognitive failures that it has revealed. So we developed a typology of problems, and I'll run through it. The first was around sequencing, length, and sensitivity. So, in doing this survey and talking to people about it, we found out that there was often problems with the order of questions. For example, in the respectful maternity care module, we had put questions about disrespect and abuse right up at the front of the module because we were worried about respondent fatigue, and those were our most important questions. So within the first couple minutes of this module, you're asking them, were you hit or abused or slapped while giving birth? And some of these questions were really emotional for women, and they kind of felt like out of the blue and shocking to ask them right up at the front. So we realized that it's a lot more appropriate to have those questions at the very end once they've kind of gotten the idea of the survey and they've warmed up to the questioning. And they've also kind of come to understand the period of time you're asking about. They know it's about their most recent delivery or their most recent antenatal care experience. We also found that it was really long for respondents, and this comes up in several different ways, but one major one is on infant and young child feeding and family planning. We would have questions about their practice. When did you first start complementary feeding? And then we'd have questions that mimic those, but they were about their knowledge. So like, when do you think you should start complementary feeding? And to women, these sounded exactly the same because they weren't able to kind of think about what they did and a goal of like correct knowledge of what you should have done. Knowledge was very embodied and experiential, and what they did was what they meant to do was the thing that was right. So they would feel like you're asking the exact same question twice. We found a number of problematic response options. And this one, I think, is, if you take away anything from this entire talk, take this away. We tested so many different Likert scales. We tested it using words. We tested it using words and colors. We tested it using numbers and stars, stars and colors. We tested longer scales. We tested it with smiley faces and Hindi numerals. We just tried everything. And what we really can tell you is, please do not use longer Likert scales with certain populations. These women, who were a kind of cross-section of rural Madhya Pradesh mothers, so, talking ages 18 to around 35, 40, some of whom were fairly educated, a lot of whom were not. They really did not resonate with Likert scales. They would often refuse to engage with the Likert scale at all. Like, they just wouldn't even look at it. Instead, they would just agree with the question or say, no, that didn't happen. Or they would look at it and be just like, oh man, like they would be shaking and nervous. They would feel awful. We had really skilled really skilled researchers. Deepan Mehta was one of them. We had others who'd worked for years, in this population, and they would try to explain things in many different ways, and they just could not get these Likert scales to work. And, Likert scales are often the foundation of surveys, and people use them all the time without testing them. So I would really emphasize that they don't work. And I'll just give one more example. When we tried the smiley face scale, which a lot of people said, oh, that one's going to work. Use smiley face. Of course, the other ones don't work. The smiley faces will work. We had some really surprising responses. So we said, the doctors, nurses, and other healthcare providers did everything in their power to help manage my pain while you're in labor. And or we had another one that said, the doctors, nurses, and healthcare providers explained the results of the tests that they did. And in both cases, this respondent pointed to the saddest face. So I'll go back, the sad face there or the sad face there. And on probing, so in a regular survey, that would have been recorded as a, disagree. They didn't help control my pain. They didn't explain things to me. We would have moved on, but we talked to her about it. And she said, oh yeah, they were fine. Yeah, they told me, but I was in pain. So my face looked like this. Or, you can't feel happy till the baby is delivered and healthy. So until then, I was feeling like this. So, really different responses that you just could not have predicted, and really highlight that these scales don't work. One thing that we found is that converting yes, no responses or longer Likert scales into 3, so maybe you can call it a 3-point Likert scale, really did work for a lot of women. And it also allowed them to express negative experiences that they might not have wanted to express if it was a yes, no. So like, did you feel any hesitation, fear, discomfort in talking to the healthcare providers? So in asking the healthcare providers questions about your delivery, and it always felt hesitation, sometimes felt hesitation or never felt hesitation, that really gave them response options they could use. And the sometimes felt hesitation allowed them to kind of make a complaint about the health services they got without kind of feeling they were being too harsh or negative. And, how good was your overall experience? People wanted this on a long Likert scale. We found a 3-point Likert scale, very good, somewhat bad, and very bad. That was enough. That worked. Questions that required respondents to speak the names of contraceptives failed. Women did not want to say the word condom. They did not want to say, any of the contraceptive language. So when you ask them to name methods, it was very awkward and it failed. Asking people, like saying statements and then asking them to say whether this is true or false, like you can use family planning while breastfeeding. People don't in their normal lives talk like that. They don't say a statement and then say true or false. It's better to say like, is there a contraceptive method that can be used while breastfeeding? Yes, no. That felt way more natural to people. Inappropriate vocabulary and long sentences. So we had this funny experience where we're doing the interview. I'm sitting there, but I'm not talking, I'm listening. And the interview is happening in Hindi. But the words used, the vocabulary in these questions, which are questions that have been very carefully and thoughtfully translated, many of which have been used in Hindi-speaking populations before, were so foreign to these women that they actually asked the enumerator, please speak Hindi to me, even though that was in Hindi. So, you find out that these key words in the questions are absolutely not part of their daily language, not understood. And women just soldier on. They give you an answer. They don't ask you, what's that word mean? And when you probe, you find out that they didn't know what you were asking because those words were not understood. So this is just one short list of some of the most, like, imagine trying to ask a question about breast milk or consent and using this key word and it's not understood. The question just completely falls flat. We had an interesting one about pills. All of the different contraceptive pills, goli, women knew. So they would hear, do you use the blah, blah, blah pill? Have you ever heard of the blah, blah, blah pill? And the word in front of pill, emergency contraceptive, oral contraceptive, medical termination, iron supplement, those words were not known. So they would just hear about pills, all these questions about pills, and they just answer thinking about whatever pill was on their minds. So you got to be really careful about the language. We were able to address some of these by just selecting a more commonly used word. Others, we were forced to write wordier, longer questions. So you can't use family planning or contraception. So you have to say ways or measures husband and wife can use to delay or avoid pregnancy. Sometimes we found that you'd have to use multiple options because some worked with some women, some worked with others, and you could not find the perfect word that worked for all the women. So we're asking about positions that you were allowed to be in during labor. And, we found that you had to say knee bent, squat, sitting on toilet position, and one of the three would work. And you provide those in the question itself for the enumerator to know that they shouldn't just use one. And sometimes you just had to use a clarifying example. So here, we had, did the doctors, nurses, or other staff at the facility ask your consent before doing procedures and examinations on you? What we did instead is we said, did they take permission from you before doing the vaginal exam or any other exam checkup? Because doing procedures and examinations on you was just so abstract. But if you said the most violating procedure that you're most interested in consent about, and then said, or others like that, they could follow you along. Temporal and spatial confusion. So we had a lot of confusion about labor versus delivery. Even the enumerators themselves were finding this confusing. A lot of labor rooms in facilities don't shift. Like, you're not in a labor room and then you go into the delivery room. So there's no clear movement. So you're not really sure, are you in labor or are you delivering the baby? So there were questions about who was in the room with you during labor and who was in the room with you during delivery, trying to understand birth companionship. And the differentiation was very confusing. Which interaction with health workers? So we were trying to understand how people were treated at like antenatal care. And we'd realize they were answering the questions about like Some other time they took an older kid for immunization and they weren't pregnant at that time. Um, we asked, were you allowed to move around during labor? And they said, well, yeah, we drove there in a vehicle. Like, we moved while I was in labor, but it wasn't about their physical autonomy to labor in a comfortable way. Were you allowed to drink and eat and drink during labor? Yes. And then we talked about it and they said, oh, yes, they advised me to have SOG, pulses, dahi, plenty of water, talking about the entire pregnancy. Assessing different cognitive domains. So, we had an interesting experience on this where we realized the questions were just talking about completely different things to each other. We asked, would you recommend this place to other women? And the woman would reply, no. But she was thinking about, I don't really speak to other women. I don't have the authority to tell others what to do. Or I don't get out much. How can I tell others what to do? It wasn't an issue with the quality of care necessarily. Would you return to the same clinic for your next delivery? She would say, no, I'm not having another baby. I've been sterilized. I'm done. Again, nothing to do with the quality of care. Or she would say, yes, I'd go back to the same facility, but it's because, we'll be too poor to go anywhere else next time. We'll never have the money to go to a private facility. So yeah, I'll go back, but I'm not saying it was a good place to deliver. For how long did you exclusively breastfeed? And she said, she was thinking, okay, how long did I give breast milk as the main source of nutrition? 6 months. I know that's the right answer. And that's the thing I did. But I also gave the baby Janam Gutti. I gave water because it was the hot season. I did lots of other things, but that's not relevant. They're asking about this main source of nutrition, not, little other things I did. So you're really not measuring exclusive breastfeeding according to like the WHO understanding. There are many more, but those are some examples. And finally, failure to resonate with the respondent's worldview. So these are questions that, really didn't map onto each other. And a good example here is around consent. So we have a lot of questions in the respectful maternity care space about consent being a marker of quality. And it really assumes that women consider that it would be appropriate to be asked by health workers about procedures. But women they did not feel that way. They would say things like, I went there, so of course I wanted the doctor to do the procedure. Or it was hurting and it's their work, so of course they will do it. Being asked during that moment of pain would actually be considered a bad quality of care. So really, these are global domains of consent, but they don't resonate in all contexts. How can diarrhea be prevented? We realized that women would launch into treatments of diarrhea, and upon probing, they didn't have the concept of prevention. Diarrhea was something that just happens. It happens to children. We have lots of treatments, but it's not something you prevent. Being involved in decisions about your care. This assumes that being involved in decision-making is a marker of quality and respect. This is also a global domain, but women often did not conceptualize healthcare in this way. They said, I went there so they could do what was supposed to be done. I didn't want to be asked. So, that's really tricky. Were you involved in decisions about what or when to feed your child? And this assumed there was this sort of like family decision-making process on, okay, now the child is 6 months. We should start complementary feeding. We should choose which foods to complementary feed with. But it was much more that women said, look, it's just my job and I just do what's done. There wasn't this sort of like decision-making process along the way. Okay, so hopefully I've kind of shown you that there's a lot of surprises that come up during cognitive interviewing, and that if you skip it, you may never know that your questions are not working. I'll talk a tiny bit about methods. And I'm just pulling up a image that I can share later about the process of tool development and where cognitive interviewing fits in. And it's really just to highlight that it comes before pilot testing. Pilot testing does not do what cognitive interviewing does. I think some very good teams involve some of the cognitive interviewing practices in their pilot testing process, but it's just not enough. So much of pilot testing is much more focused on skip patterns, like obvious problems that everyone can notice, but it doesn't really look for the deeper challenges. So with our process, we decide the scope of cognitive interviewing, select and train our researchers, sample participants, conduct a small set of interviews, do a very extensive team debrief, revise the tool, and go back to the field again and do multiple cycles. I'll just briefly mention, I'm just going to check our time. I want to go over. Good, we're on track. Briefly mention the scope. So you often will have an hour-and-a-half long survey tool, and it might contain 180 questions. You're going pretty fast when you're doing a quantitative survey. But as you know, cognitive interviewing requires that for every question, you actually conduct a small qualitative interview about that question. So you can't possibly sit a woman down who would take 90 minutes to answer the questions in a survey and cognitive test all those questions on her. You'd be there for 8 hours. You'd be there for ages, right? So you really have to decide your scope. Can you cognitive test all of them by breaking them out into smaller sections? Do you just pick a few priority ones, maybe the newest ones, the ones you're most worried about? You have to really decide what you can handle, what your scope is. So what we did is we pulled out, our biggest outcome measures for this example time was on infant and young child feeding and family planning. So we didn't test a whole bunch of questions on like phone ownership and on general family health and on expenditure. We just pulled out the 30 questions on IYCF and 30 questions on family planning. And then we left the other questions behind and did not test them. And we tested those IYCF questions with one round, like one set of cognitive interviewing, and the other ones with a different set, different respondents, different process, and sampling. So the participants should have the same profile as the intended survey respondents. Obviously, if you're doing it with postpartum women in Madhya Pradesh, pick other postpartum women in Madhya Pradesh. But you can save a lot of time on this method by choosing the women who are most likely to struggle. Because usually, if you can get your survey to work for these women or these respondents, it'll work for everyone. So for example, if you pick the women who are less educated and most marginalized, we found women who kind of expressed a sense they don't get out much, they hadn't gone to school much, maybe they were married quite young. These women are highly marginalized. And so their exposure to complex vocabulary words, their mental processes are, if you can get your survey to work for them, it'll work for everybody. So you can really save time by targeting your sample. And it's iterative, as we showed on that other slide. So just to kind of give you a sense of how that looks. For family planning, we had a first draft of questions that we got from DHS surveys, CARE, etc., on knowledge, practice, self-efficacy. And so we did 10 cognitive interviews. That was version 1. Then we stopped and we did a strong debrief process, and we revised the survey to get version 2 of the survey. We did 6 more with version 2. We sat back down and we did a long debrief, and we developed version 3. And we took that version to the field with 5 more women, and we tested it, and we found by then it pretty much worked. So we did a few tweaks and ended up with our final version. So we're not talking massive numbers of women. You can do a lot with small samples, and you'll be amazed by how many cognitive surprises you find. All right, I'm going to turn it over to Deepanvita to have some of her reflections about being a researcher in this process and how it felt and what she can share with you.
Thanks, Kerry. Hi, everyone. So far you have listened to wonderful findings of this study, and will share my experience being in the field, conducting these researches. So starting with the respondents. So we know for all the research work, respondents are the critical part of every project. But the respondents in cognitive testing and how they reacted to questions were a bit different. So like Kerry mentioned, there were first a survey question, and then followed by there were cognitive probes, which were like a bit more of in-depth qualitative research questions. So while during the consenting process, while during onboarding the respondent, it was made clear to them that the intent of the interview is to improve the survey questions and not to assess the respondents' understanding. Still, when the questions were asked, most of the women, they appeared anxious, as if they were being tested or quizzed, and where they felt like they were failing to understand the questions and responses. There were some respondents who actually preferred to give response to the questions in yes and no format. So like earlier, Kerry was giving me an example, like the Likert statement. So the Likert statement was asked to her, but when the respondent was reverting back, she made sure that she converted the sentence to a question and replied into yes or no. So despite the repeated try by the researcher to make them understand that we need an answer in this format, they felt like maybe I'll choose a wrong response, or maybe what if I didn't get the answer. So there were a lot of questions like this where the respondent actually didn't open up and speak to us. So asking them question about, if you have any doubt with the question, if you need any clarification, do ask us, or we can repeat the questions. But there were respondents who actually spontaneously gave response like yes and no immediately to the question. They didn't think for a second. When probed, it was found out that they had confusion with the question. For example, when asked about what would you say the health facilities washroom were very clean, somewhat dirty, or very dirty? They said dirty. Okay, but sorry, they said clean. But when in the previous question to this was about the water supply in the health facility. They mentioned only once there was water supply to the toilets. So how can a toilet be clean if there's just water supply once a day? So when probed into this, it was found that she was confused which facility to select, because she has been to a Anganwadi center and also to a hospital. And the toilet at the Anganwadi center was clean and the toilet at the PHC was dirty. So yes. So still after explaining repeatedly time that if you have any struggle with the question or answering any question, you can ask us to it. Still they refrain for asking us. So they felt very bad or self-conscious when it became very clear that they don't understand it, or the few responses, or it's like they are repeating the same yes and no again and again, and not trying to get in with detailed discussion about the situations, or having difficulty in recalls. They thought they will be judged. So like every other research consenting thing that happens prior to the interview, but for cognitive testing, many parts of the consent we have to actually repeat it while we were conducting the interviews to make the women comfortable. So whenever I and other researchers saw that the women are becoming anxious or they are hesitant to speak, so few of the parts of the consent we repeated again and again, like the confidentiality, that this information remains with us. This information cannot be linked with any other with you or to the village, or to it will not share with the any government. We are not from the government part. We are a researcher and everything. There's no right and wrong questions. We are interested to understand your experience. How was it? And the suggestions which we are asking from you will help us to develop a questionnaire which will be easy, so that people can understand what you are saying. So we can use it with the other women in the like you with the same questionnaire, who will understand easily about the terms and the concepts. Still, there were few things that the researcher who actually failed and found challenging was the few concepts which actually doesn't resonate with the women's reality, or they couldn't understand the hypothetical situations. For example, the concept which Kerry has already shared, that the consent. So they felt like, what is this consenting thing? If I am pregnant, I have gone to the hospital for delivery, then why should someone ask a consent from me to do the test? So I have gone to doctor will do the test. Then there was one respondent who said that the female caregiver, the doctor was female, so she can touch a female. So there is no, so gender wise, there is no need of consent in this process. Then with the different positions for birth, so there's no awareness among the group we were doing the interviews, that there are different birthing positions. So they didn't know. So what they knew is lying down and being in lithotomy position and delivering. So asking them question that whether were you comfortable in this position, the position you delivered? They were like, yes. Like, why will I not be comfortable? What are the other things? So that that was something surprising to them. So yeah, so as a researcher, we literally struggle to explain those situations and they make them understand, okay, this is what it mean, and what will you wish to respond to it. Coming to time, definitely it's the cognitive interview process is a time consuming process, starting from the field work. So each interview can actually last to up to an hour or more, depending on the length of the questionnaire and how the respondent are engaging in the discussions. So a maximum interviewer can actually conduct 1 to 2 interview per day, not beyond that, because it's a very intensive process. Once physically, because being in field and in different setting and trying to conduct the interviews, and also they have to kind of attentive all the time, and they have to be analytical and joining the dots basically. So if there are questions which are connected, so why the responses are varying. So both mentally and physically, it's an intensive process. So 1 or 2 interviews maximum a researcher can conduct a day. Also during the research, it's be audio recorded, but we also took note of the non-verbal cues, the other observations which a dictaphone cannot record. Apart from the field work, other process which is very critical to this is the debriefs. So with this study, we did debrief every day religiously, and it went as long as 1 to 2 hours, even more some days. So, and all the team members, starting from Kerry to the research manager, other researcher, everyone joined in this debrief calls. We discussed about what are the problematic areas where we can make revisions. Every researcher shared their experience. What is something unique they have found out today? Which question has not worked at all? Which question worked well? What if they have come up with some new words with maybe for the translation that has worked well, so that the other researcher can use that words in the next interview and see whether this is like more easily understandable word rather than what is there already translated in the questions. Also, one more thing, that every researcher gave some time after the fieldwork was done in reflecting and documenting their interpretation of the interviews. So every researcher note down their reflections on how the respondent reacted to the interviews, how was the environment, what is their perception, anything interesting, were any information shared after the recorder was turned off, sort of thing. So everything was recorded. Coming to researcher, like Kerry has already pointed out, not a data collector, but a researcher to conduct a cognitive interviews, and definitely one who has experience in the qualitative research field. So, because cognitive testing needs a person who is far more skilled and technically in the subject matter, because there will be, so when going in depth of anything, which could be anything, so we are just giving them an open question and they can share their experience to any extent. If the person knows the subject matter, they know what the woman is talking about, and what could be a follow-up question to do is to understand their perception of that particular question. So for this, because it was about RMC, so all the researchers which Kerry selected were experienced in maternal and child health field. They have been into fields, they have worked in various projects which were involved in maternal and child cares majorly. And apart from being a qualitative researcher, it is I felt like it is very important to be competent in the interview process, because the interview processes can take time. So you have to be patient. You have to wait for the person to recall the moment, because if she has delivered 4 months ago and now you are asking about what was your position during delivery, she might take time to recall, because she was in pain, she was going through a lot of things, she cannot recall it immediately. So you have the researcher has to be like patient enough, attentive also, so that they can pick up what are the dissimilarities between the conversation, and at times analyzing. So this judgment is very important to how many cognitive questions you need to ask. You cannot end up asking all the proofs which were given to you, because that will be like you'll end up spending more than an hour, half an hour in discussing one question. So how much to ask, what to ask, so that you respect the time of the respondent also. So yes, and definitely training. So I have been in part of various in many researchers, but this was something new. This methodology was new to me, and so as to the other researchers. So Kerry did organize a thorough, rigorous cognitive interview training for us, where we went through what are the concept, what is this concept of cognitive testing is all about, what are the objective of this project, and what is that we want to achieve, and especially going through the questionnaire one by one, understanding each questions in depth, like what is the objective that each question is actually intending, what is that we want to know. Okay, so yeah, so this was the training part. Kerry, do you want to add anything?
No, I think that was fantastic. I mean, the one thing that it reminded me of is like, never ask the respondent, did you understand? Because they'll always say yes. It's only through like the clever probing and the making connections across different questions that you can actually figure out there's cognitive failures. Like the example about like, you knew there was no water in the bathroom. So how is she saying it's clean? Or like, we knew that, you know, something bad had happened during her delivery. Why is she saying she would go back there? And then you figure out that this question is not working. So I really think that's such an important point. And I thought, like, finding good researchers for this, Deepanvita is so right. Like, they really need to be skilled. And I found that like we've had trouble with some researchers just get kind of too focused on the quantitative answer to the question. So during the interview, when they're supposed to be focusing on like wearing the quantitative hat and then switching to the qualitative hat, they're much more just like trying to get through the survey. And it's like, no, we're not actually going to even crunch these numbers. Like, we don't care what they said. We try to understand if the question worked. So it can be hard to like really get your research team to kind of come on board with this new method, because they're not used to being like two different researchers at the same time. Or you get such great qualitative researchers that they don't ask the question as if they're a quantitative enumerator. They immediately start explaining the question, giving synonyms for words. So they create a initial question that is actually not very likely to be asked by a regular enumerator at a 5,000 woman survey. So you really need the research to understand that like you have to like first ask it like an enumerator and then ask it like a qualitative researcher. And I think just to expand upon Deepanvita's point on subject area expertise, like we had times where this is like a big one for family planning. It's like, and I kind of learned the hard way because we didn't spend enough time talking about the details of how each method works. Because women would say like, I got the like 3-month one, I got the 5-year one. And it wouldn't be clear whether they're talking about like depot shots or like the rod implants or an IUD. So you have to spend a lot of time, like, because if they say, oh, I got this, I got the shot, you got to make sure they're not thinking about getting like the tetanus shot or some other shot that's not related to family planning. Or if you know that they haven't had a baby for years and their husband is home all the time and she won't say the word like condom, but she's already said she won't use all these other methods, you kind of have to like slowly figure out what's going on with her family planning use. So you have to know about the methods. So yeah, the training has to be really thorough about methodology, about subject topics. Yeah, and I think that's all I wanted to add.
Yeah. Can you go to the next slide, please? So yeah, so here's an example of an interview process. So I'll just quickly go through it for the interest of time. So here the respondent asks, so did the doctor, nurse, or any other health worker took your consent before performing test? Respondent, no. Where? At the Anganwadi. Researcher, no. When you went for delivery, did doctor, nurse, or any other health worker took your consent before performing the test? Yes. They asked about how much pain I was experiencing, from when I was having pain, etc. Okay, so here the researcher explains, okay, I'm asking you whether they took your permission for performing the test or checkup. the immediate answer after just changing the word consent to permission, the answer was no. What did you understand by permission? It means, should we check you or not, as you are experiencing pain? So did they not ask permission, or did they? She said no, they did not. Which term was easier for you to understand, consent or permission? The one which we use most often comes to my mind is permission, I mean. And after this, there were following questions where the researcher actually took name of each of the procedure and asked like whether the permission was taken. And to all the procedures, she said no. But if you look at the second response, which after the question was repeated, she said yes, the consent was taken. This was her interpretation what a consent mean, like basically asking her about the pain is what she felt is consent. So the chief complaint is what she thought is taking consent. Similarly, like Kerry said, that if we would have noted as a survey response, then yes, would have been the response. But now towards the end, the response was no. She didn't, the consent was not taken for any of the procedures. And also there's a point to add here that the word permission, so the word which we used was not anumati, it was permission. So the English terminology worked well rather than the word anumati. So a point to note that there are few English words which are very commonly known among the people, maybe also in the rural part, and they gets it very well. So yeah, within interest of time, I'll skip the next slide. Over to you, Kerry.
All right, so just to let you guys know that Deepanvita and I, with team members, published the findings from our respectful maternity care cognitive testing. So you can read more about it. And with some other colleagues, I've also published a methodological paper on the value and application of cognitive interviewing, and how it's like, you know, they use it fairly often in the US, and sometimes you'll see it pop up elsewhere, but it's still pretty common to see people develop surveys and use surveys without doing it. So I'm really, my goal in life is to see it become an essential part of every survey development process. And it becomes like, you wouldn't do a survey without pilot testing. Well, you also wouldn't do a survey without cognitive interviewing. So that's my hope. So please, if you're interested in these papers, you can grab them. They're both open access. And now I'm going to turn it over to the group. I have some kind of discussion starting points, but we can really go in any direction you want. Ideas to kind of get us going are, you know, even after extensive cognitive testing, questionnaires remain vulnerable to cognitive failures because of different ways of thinking and being. Do you agree? What do we do? And that kind of links to the image I put on the slide of like the abstract art. Like sometimes you just will not be able to get people to see things the way you do. And so, you know, is this true? Can you ever get a perfect survey? If not, like, is it okay to just continue with knowing that some questions might not work for some people? Have you used cognitive testing? How have you taken on these issues of scope, sampling, sample size, etc.? And like, what should we do when internationally recognized domains don't resonate? Like when being involved in decisions about one's care is not considered a marker of quality by these women. Do you keep measuring it anyway, even though it doesn't really work, so that you have a comparable measure across time? And, you know, what do you do? I'm going to turn it over to Shirley to, like, if you want Shirley to facilitate discussion, or people can just, yeah.
Yeah, thanks so much, Kerry and Deepanvita. This is really great. I know, like us at Nora, we do many surveys, and I think there's a lot of food for thought here in terms of things that we can think about bringing into our processes. Folks, you're more than welcome to add questions to the chat or also come off mute. If it's all right, I think, Rizu, I think you're still on call. If you would like to come off mute, I know you put a question in the chat. I can also read it out for you, but if you want to come off mute, you're also welcome to read your own question.
I think Kerry's like sort of last question and the first question, that is where, you know, my thinking was, and, you know, my question was, because last year I was kind of involved in a very large scale survey in Bihar, where, the kind of issues Kerry was talking about, that, like, I mean, I really felt like an outsider, doing this evaluation, where concepts that, you are bringing in and asking people about are so distant. And like it like really made me think about, the power dynamics of the communities and, of the researchers, which this is not the first time, that I felt that, but in a survey, it really made me feel even more so, because these internationally recognized standards of quality, where you're saying, okay, like, did somebody ask you this, and people in the community don't think that that is a marker of quality. So that was very interesting, and I just wanted to ask Kerry if, like, she had any more insights into that. Thank you.
Oh, thank you, Rizu. That was, yeah, I mean, it's so good to hear you also express that you felt similar things. And one thing that was striking to us is, like, Deepanvita and Biba and like these other team members, we were all, not me, they were all really experienced researchers in Northern India at that time. And they had like read the translations that had been developed, and they didn't think they were completely off. They thought, like, this is a fairly reasonable tool. And so we were all pretty mind blown when it like really didn't work. And it just kind of shows that, like, I think cognitive interviewing, it becomes like, it's always important, even when you're writing questions for your peers who share the exact same education and worldview as you. But like, the further the gap between the researcher and the respondent, the more striking the problems with cognitive interviewing are. So even like Hindi speaking researchers familiar with the field were still fairly different than the women who we were talking to, who had low exposure, low education. And so that gap really creates more and more of these cognitive mismatches. But yeah, like, what do you do? I mean, I've become like really skeptical about survey findings. Like, I read everything with a grain of salt. I'm like, really, 20% thought this. Like, did you test your question? I mean, you start becoming like a total skeptic if you don't think they've cognitive interviewed. And it's really challenging because
Yeah,
so
exactly.
often,
Like, I
yeah,
think I became such a skeptic. I was like, okay, what are we measuring? What are we getting? Is this any use? Like, yeah.
yeah.
But I think it's very important to keep that balance. Yeah.
And I think, like, I don't believe in throwing the baby out with the bathwater. Like, we do need quantitative large scale surveys, because that's what like policymakers need. That's what allows us to track progress. But I don't think it makes sense. Like, I hear groups saying, we don't have time, we don't have budget to cognitive test. And I'm like, you're spending like millions of US dollars, you're wasting 5,000 women's time, and you're not going to test that your questions even work. Like, how is that even reasonable? So I get really like fired up about this. And I just think that, we should create this norm where if you're going to take that many people's time and sit with them for like an hour, hour and a half each, you should make sure the questions are good as they can be. And I think that if that means you don't have standardized measures across contexts, so be it. It's better than misrepresenting reality, because you make policy decisions, you allocate resources based on the quantitative results you gather. So if you're misrepresenting reality for those women, then you're doing the wrong policy decision making. So I think that it's hard. It's really hard. But I would err on the side of localization and just give up on like comparability across different countries or different states. It's a very controversial decision though, because I can totally see the other side. Like, you need global data to say, oh, India has this percentage of women experiencing this, and Kenya has that, and Canada has that. Like, there's so much value in these things, but if the trade-off is that the question didn't really work, yeah, it's hard.
So I have a question, Carrie, Deepanvita, like, if you can help me understand, at any point did you feel during your interview that gender might have been a problem, like in certain questions, the women might have answered differently if it was done by a male interviewer, like especially questions on family planning, for example. And if that was a problem, then how did you tackle that?
Yeah, Deepamita, do you want to go first?
I think what I could recall from the questions, so not more in terms of gender, but in terms of power. So they figured that the doctor is more powerful, and the not the respondent has gone to a doctor to get the care. So that power thing was, so definitely with the RMC question. So Kerry, you can add like if there was other question which had this gender thing more prominent there, but not in terms of gender, but definitely power wise, what we felt was different at with the RMC questions, where they felt the nurses, the doctors, the healthcare provider are powerful and they don't have a say in their care or consenting, saying yes or no or anything on their own. They have anything to add on to their care.
Yeah, and I
Uh,
think, I mean, when we do the cognitive interviewing, we try to replicate to some extent what will happen at scale with the enumerators. So just like, in India, you would not have men interview women about family planning. We would do the same. We would make sure it's women doing cognitive testing on all the family planning questions. So I think, gender in India is like pervasive, and you would just be really thoughtful about that. But the power that Deepamita mentioned is probably less striking, but equally important. And I'm talking about the power between the researcher and the respondent, because we found, like, I remember sitting in interviews where the woman started to, she was like shaking. She was so nervous when they kept showing her Likert scales and kept asking her to engage with them. She felt like she didn't feel great, and we had these really kind researchers who were like, we're trying to make this survey work. If the questions are bad, like, it's our fault. It's not you. But they just kept feeling like they were failing because they weren't understanding the words. So it's really hard to ask these questions in a way that is not really scary to women. And I think part of the training is to really tackle this issue of, like, how do we come across as like it's our fault if the questions don't work. It's our fault if this Likert scale is inappropriate. And the power dynamic between our educated elite researchers and these women who are feeling like they're coming up short with their vocabulary knowledge is really problematic and striking. So that, yeah. One other point about gender, though, that was kind of interesting is we had a lot of challenges getting the husbands to leave and let the researchers talk to the wife alone. And actually, sometimes when they were around, they would say completely different things about her experience of care. Like, they were saying, like, oh, the doctors were so mean to her. And she was like, no, things were fine. Things were fine. Or, like, we had some questions about payment for services and, like, informal, bribery and things. And the husbands knew more about that because the woman was recovering from C-section. She said there was nothing like that happening. And the husband's like, are you kidding me? I had to run around and find money for this and that. So it's not that the husbands were probably like bad, like they were trying to help get the right answer onto the survey recording. But since we wanted to understand how women comprehended the questions, the husbands kind of came in the way because they often understood the vocabulary more than the wives. And there were times when they actually experienced different treatment of their wife during labor than she experienced or was willing to report. So that's like totally worth exploring, but we didn't get into it. We just tried to get the husbands to leave the room.
okay, thanks, Kerry. It was
Thank
very
you.
interesting what you talked about, like, husband being in a room and how that affected their the way the women answered the question. It's very interesting. Thank you so much.
Thank you. And you got a real sense that they were trying to kind of like defend their wives and like point out that there were problems, whereas the wife was trying to say everything was okay. So they were really trying to be advocates for her, I felt, but they did come in the way of the cognitive interview.
Just pause in case anyone has other questions.
Yeah. Oh, Shirley, I saw you had a question about how we introduced ourselves to the participants.
Yeah, I can share more about sort of where that questions, well, it's always relevant, but I think for us at Nora, we typically, our program is attached to the public healthcare system. So when we call, we do say we're calling from this hospital, which comes from all the power dynamics that Deepamita spoke about and obviously influences many things. But yeah, I'm curious, given the sort of first slide that you showed of all the different partners you worked with, how that how you guys entered and began the conversation with participants.
Yeah, it definitely differed by project. Because as you said, the one on consent forms in South Africa, it was like the government wanted us to develop those consent forms for them. And that brings, power. Like women feel like, oh, I have to consent to all this stuff because the government's asking. Whereas for the other ones, like for the one that Dipanvita did, we were somewhat removed. We were doing an evaluation of a government program. So for that one, I felt like it was pretty comfortable to say we're not from the government, we're from OPM. That was back when we were both working with OPM. But I don't know, it's tough. What did you think, Dipanvita?
Also, so even if you're connecting with the women at their places, they know if you take government's name, they'll always feel the ASHA is from the government side. They know the ANMs from the government side. So the chances of opening up and talking more about it, it becomes challenging there. Or I think there were other projects where we had to say that Bihar Sarkar, like from the government of Bihar and all, but we put more emphasis on the point that no question is wrong or right. We are here to understand. The purpose was more highlighted rather than saying from where we are more, so that in a way we gain the confidence of there that we'll keep that confident. It's not linked with the ASHA or the ANM or anyone.
Mm-hmm. And I think so much of this cognitive interviewing stuff, I think has to happen with consent forms themselves. Because when you actually look at the consent forms, that get approved by IRBs, often they are bonkers. The language is just so bad. The concepts like remuneration and confidentiality, what does that even mean to a woman? And then you translate it into Hindi and you get some translator who's using high Hindi. And first of all, the words are crazy, but second, the concepts are totally crazy for a lot of women. And so I think that most consent forms are highly problematic and no one ever gets funding to test and improve their consent forms. So yeah, that's all just linked.
Yeah, it's a good point. Yeah, no, it's, oh man, jeez.
It just makes you be like, all this research is so.
Yeah, it's hard. Yeah. Trying to fit very complex experiences and ideas and concepts into very clean text, which is an impossible task, really.
And I do think that consent forms are often serving the interests of the researchers, not the participants. This is getting a bit on a tangent, but we've had IRBs insist on getting us to take signatures from women or fingerprints. When we've very clearly said this makes them uncomfortable, they're not literate, they don't know what they're signing, let us take verbal consent, because then they feel comfortable and they can hear what we're asking them and they can reply to that. It feels way more fair to them. And they have a history of, land being stolen because they signed things. There's a history behind that. And even saying all that, and we'll record it, so we're not going to cheat, we're going to get it on recording that they're consenting. They still say, no, but if you get questions, it's better if you have the signed form. Better for us, sure, but I thought consent was for them. But it's they come at it from more of a legal protecting yourself attitude.
Sure. Yeah. Ooh, yeah. Lots of things about IRBs and consents.
Yeah.
Awesome. Well, I want to be respectful of your time, Kiri. But thanks so much for waking up early for this, and thanks so much for this great session, both of you. It was so great.